Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you're aware, all our lectures are available on YouTube. We also have a Telegram group which you can join, which is very helpful for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are uploaded. You can access them freely. These are the disclaimers. And we are with phase 3, which is recorded pathology lectures. And today we have Pursue 9V, which is Cytopathology, and we are streaming from the Department of Pathology, Nagpur Medical College, India. And today's topic is cervical cytology, defining the undefined squamous cells. And to talk on that, we have somebody who's national and internationally famous, Dr. Meherbano M. Kamal. She's an MD, PhD, MIAC, professor and HOD of the Department of Pathology, Government Medical College, Nagpur, India, trained in cytopathology at AIIMS, New Delhi, with 36 years of teaching experience, 29 years of teaching postgraduates as guide, past president of the Indian Academy of Cytology, national editor for Acta Cytologica, with more than 35 publications, editor of monograph and atlas uterine cervix cancer and TBS, contributed chapters in the book Colposcopy and Cervical Cytology in Gynecological Practice, research grants for cervical cancer by ICMR, Chitnavis Trust, INCL Indian, Philadelphia and ICMR, convener for national and state level conferences, symposia and workshop in cervical cytology for the last 20 years, faculty for the government recognized courses for cervical cytology and colposcopic studies, has multiple international presentations as well. With this, I would request Dr. Meherbano Kamal ma'am to start her talk on cervical cytology, defining the undefined squamous cells. Over to you, ma'am. Thank you so much.
A very good afternoon, everybody. Friends, any talk in gynec cytology is incomplete without paying tributes to Dr. George Nicholas Papanicolaou and his wife Andrew Mahim Avrogeny, who gave birth to cytopathology as a subspecialty of pathology. This scientist couple was bestowed with many awards and accolades for their untiring efforts in this field, but the highest honor came in when the scientific community at large decided to name cervical cytology as the Pap smear. Not only the Pap smear, but also his reporting categories, that is classes 1 to 5, were adhered to for almost 4 decades. But as our understanding of the pathogenesis of cervical cancer and its precursor lesions improved, the two-tiered morphologic classification of the Bethesda system came into existence, and which is based on the realization that LSIL and HSIL reveal different pathogenesis and that HSIL can arise de novo when the infection is with the high-risk viruses. I have separated the two diagrams on the screen to emphasize this fact. The success of Pap smear heavily depends on mastering the technique of collecting cervicovaginal smear. Although this is the domain of the gynecologist, it can also be mastered easily by we pathologists. A cervical smear adequately collected from the squamocolumnar junction and the transformation zone well fixed and well stained is still a very simple, economical and convenient method for the detection of the crime committed by the culprit HPV virus. A variety of spatulas, brushes and brooms of different sizes are available in the market and designed to reach the squamocolumnar junction and also cover the transformation zone. Whichever device we use, the commonest condition that we are required to sample, at least in the developing countries, is an inflamed cervix, and the smears in our reporting tray are 70 to 80% of the times they are inflammatory smears. More often than not, a variety of pathogens can be detected in these smears, like shift towards coccobacillary flora, Trichomonas vaginalis, Candida group of organisms, herpes simplex virus, actinomycosis, etc. The epithelial cells in an inflammatory smear are unremarkable in most cases. But the troubleshooting starts when, as a result of long-standing infections, there are reactive cellular changes in the form of significant nucleomegaly. Here you can see the nucleomegaly is 2 to 2.5 times that of an intermediate cell nucleus. there is slight hyperchromasia and there is binucleation, and then you fall into the trap of whether to report it as reactive cellular changes or as atypical squamous cells. These subtle and borderline morphologic features are highly subjective and have resulted in poor reproducibility and overinterpretation of ASC-US. The term undetermined significance might reflect either an exuberant benign change or a potentially serious lesion, and this is where you need to apply strict criteria. Here you can see that nucleomegaly is 2 to 3 times than that of an intermediate cell nucleus. There is slight variation in size and shape, and there is very mild hyperchromasia. Even hypochromatic nuclei can be atypical, but what is more important is the even distribution of the chromatin, which is seen here in all the nuclei, and then this smear can be comfortably classified as negative for intraepithelial lesion or malignancy. Now in this slide here, the nuclei are not only hyperchromatic, but the chromatin is stippled, salt and pepper type, and is unevenly distributed in all 4 quadrants of the nucleus, and there is slight nuclear membrane irregularity. Is this exuberant RCCI, or would you like to report it as ASC-US? So whenever you are in a dilemma, you can take a second opinion from your colleagues. Also go into the clinical details and reports of past pap smears and HPV DNA testing. It is unlikely to be ASC-US if previous multiple consecutive reports are NILM and or high-risk HPV test is negative. The third option is that you can repeat her cytology after 6 months, and if these findings persist and HPV DNA test has not been done previously, it can be advised. So when do we report atypical squamous cells? What needs to be very typical of this atypical category is that the cells in question should be showing squamous differentiation, increased nuclear cytoplasmic ratio, and nuclear abnormalities. And if these nuclear abnormalities or nuclear changes are equivocal, that is qualitatively or quantitatively insufficient for a definitive interpretation, you can report it as ASC-US. At times you may see only an odd cell showing multinucleation or cytomegaly, or occasional cell with a smudged nucleus may be seen here and there in the smear. The standard criteria for ASC-US cells is that the nuclear size should be up to 3 times, whereas in LSL it is more than 3 times the size of the intermediate cell nucleus, and the nucleus occupies less than 50% area, cellular area. It is either hyper or hypochromatic with finely speckled punctate salt and pepper type of chromatin, and membrane irregularity may or may not be present. Now, what is the recommendation for such patients? These patients ideally should undergo HPV DNA testing, but if this facility is not available or not affordable, the smear may be repeated at 6 months and 12 months, and if these abnormalities persist, then colposcopy is advised. Troubleshooting also starts when you see such dyskeratotic and parakeratotic cells or anucleate squams either singly or in thick dense stacks. These generally come from the surface of benign warty lesions. Parakeratotic cells are miniature keratinized mature squamous cells. When they show atypical pleomorphic nuclei, they need to be reported. In patients with a lot of hyper and parakeratosis, the true lesion may be camouflaged. In such cases, 2 smears in succession may help. You can immediately advise a repeat smear. Dyskeratotic cells are less mature cells with abnormal keratinization. There are changes in tinctorial characteristics, and abnormal shapes like fiber and tadpole cells can be seen. So in such situations, what would you do? Would you report it as NILM? Definitely not. Should you report it as LSIL? In the absence of classical coilocytes or cells of LSIL, you cannot report it as LSIL2. So should you report it as ASC-US? If not liberal, a judicious use of ASC-US as a diagnostic category significantly improves the clinical usefulness of the PAP test. Like in this biopsy, the atypical parakeratotic layer may camouflage a more ominous lesion, as I said before, and therefore colposcopic evaluation and directed biopsies of flat warts or leukoplakias can often reveal a high-grade lesion. If there is excessive reliance on the presence of koilocytes as a sole diagnostic feature, then HPV infection may be missed on cytology in around 15 to 20% smears. Factors which interfere with the maturation of cells like ossiples, inflammation, or epidermal atrophy may result in absence of koilocytes. Recognizing and reporting any two of these non-classic changes like the cell plaques, hyperkeratosis, parakeratosis, disc keratosis, increases the sensitivity of cytologic diagnosis of HPV infection and can be triaged with HPV DNA test. Reflex HPV DNA testing provides a safety net against false negative cancer screening results, and it is positive in around 40 to 50% of ASC-US cases. Till now, we saw that the nuclear features or nuclear atypia create dilemmas, but one more feature that is a troubleshooter is the incomplete or partial cytoplasmic clearing or haloing that is suggestive but not diagnostic of koilocytosis. Here in this field, you are seeing a cluster of cells, and the cells are showing partial cytoplasmic haloing along with nuclear abnormalities. The differential diagnosis of perinuclear halos includes navicular cells, reactive or inflammatory changes associated with Trichomonas vaginalis infestation, atrophic epithelial changes, immature squamous metaplasia, and these are navicular or intermediate cells that under prolonged progesterone stimulation give a halo-like appearance, and these pale glycogen-filled diffuse clear areas of cytoplasm should not be confused with perinuclear halos of koilocytes because the cavity of these cells is not sharply defined, it is not optically clear, and it is not associated with thick dense wire looping, and most importantly the nuclei look normal and are not atypical, as you are seeing in the center picture, that are true koilocytes. Cytoplasmic vacuolation from other causes like inflammations, especially associated with Trichomonas vaginalis infestation, also known as the trick halos, occupies only 1/3 area of the cytoplasm and is around the nucleus. In this picture here, although there is binucleation, this non-specific perinuclear halo is without sharp margins or nucleomegaly, and atypia is not seen. And an important clue is that the small perinuclear halos tend to affect, if not all, most of these cells in the smears. As you are seeing here, majority of the cells are showing this variable sized perinuclear halos. Vacuolar degeneration of the cytoplasm can sometimes mimic koilocytes, but you can see even the nuclei are showing degenerative features in the form of swollen pale nuclei, and these can be sometimes misinterpreted as koilocytes. Metaplastic cells sometimes have an attenuated pale staining endoplasm with a relatively dense cytoplasmic rim, but the nuclei are normal, and also these are of the size of parabasal cells, while koilocytes are more mature squamous cells, that is superficial or intermediate type of cells with all nuclear abnormalities. Till now, we were on a morphological journey trying to handle the troubleshooting created by exuberant reactive cellular changes, ASC-US, and non-classic features associated with HPV infection. Just to summarize the classical features of LSIL that encompasses both HPV infection and CIN1, I would like to emphasize that although the koilocyte is the hallmark of HPV infection and its presence alone is the telltale evidence of this infection, one must understand that even CIN1 is induced by HPV virus, but it takes a morphologic backseat after inducing the lesion. In the absence of classical chondrocytes, it is almost impossible to differentiate HPV-infected cells from cells originating from CIN1 lesion on cytomorphologic grounds alone. And this is the reason why that HPV and CIN1 have been clubbed in LSIL, and this distinction is no longer meaningful clinically. It is very common to see metaplastic cells in an inflammatory smear. Why? Because we as pathologists best know that inflammation and repair go hand in hand. But metaplastic cells at times make you stand still on the crossroad. Here, what is different about these metaplastic cells? They are slightly more mature cells and of the size of the intermediate cells, whereas here they are more in keeping with the parabasal type of cells. But more significant change is the nuclear enlargement by nucleation and nucleomegaly, and increase in the NC ratio. A nuclear to cytoplasmic ratio of less than 50%, smooth nuclear contours, and even distribution of chromatin all favor a benign process or reactive cellular changes associated with repair. But at times you see such disorderly clusters and sheets of cells or syncytial clusters with anisonucleosis and a worrisome hyperchromasia. The chromatin is fine to coarse and evenly distributed with modest nucleolar prominence. These are atypical immature metaplastic cells consistent with reactive and reparative changes, and the presence of inflammatory cells intricately mixed with these atypical metaplastic cells is a clue that this is an inflammatory process and can be safely reported as NILM. These metaplastic cells are showing a higher NC ratio with hyperchromatic nuclei and smooth nuclear contours. These cells create a confusion whether to report them as ASC-H or cells from HSIL. But if you carefully apply criteria, this you see that is a flat sheet of cells without much overlapping and is not a syncytial cluster as we get in a classical HSIL. And even the polarity of the cells is maintained within the sheet. However, the nuclear atypia is much beyond that of atypical repair. In this smear, you can see the cells are more mature looking, have a higher NC ratio, maybe more than 50% area of the cytoplasm is occupied by the hyperchromatic nucleus. So, what would you like to report this as? Would you report it as NILM? Certainly not. Should you report it as HSIL? I think not, because we did not see any syncytial clusters of immature round cells typical of HSIL or significant nuclear contour abnormalities in the form of notches or bulbous protrusions, grooving or indentation of the nuclear membrane. So should you report it as ASC-H? Yes, ASC-H, that is atypical squamous cells, cannot rule out high-grade lesion designation would be most appropriate for these cells. Also remember that morphology of cells coming from a lesion of CIN2, which is now clubbed in HSIL, may not show small round cells and a very high NC ratio, creating a diagnostic challenge as we saw in this picture. Around 10% of all lesions belonging to the ASC category are ASC-H, in which the cytology changes are suggestive of but not diagnostic of HSIL, or when the atypical cells are very few in number or qualitatively insufficient for a definitive interpretation of HSIL, the ASC-H category can be used judiciously. These are the differential diagnosis of cells showing features of ASC-H. Also, there are several patterns that can be seen, like the small cell type and the keratinizing type. LBC specimens particularly create diagnostic dilemmas when the immature metaplastic cells are seen singly and appear smaller, rounder, and do not flatten out because they are lying in a liquid medium. You need to do up and down focusing to see the nuclear details. When they are difficult to resolve any further, ASC-H is an appropriate interpretation. But at times you see very clear morphology, and the cells meet all the criteria of H cell, but they are very few, and then you can choose to report them as ASC-H. Now here you are seeing small round cells with high NC ratio, and in the vicinity you are seeing such dyskeratotic or keratinized cells. Here again you are seeing a single cell which is hidden behind the normal cells, and it is having deep nuclear indentation and bulbous protrusion of the nuclear membrane. Now, a large number of such cells, also known as the litigation cells, have been picked up by rescreening and by automated devices in the West, and therefore automation and artificial intelligence has gained tremendous popularity. ASC-H reports are not triaged with HPV DNA test, and the patients are straight away referred for colposcopy. In severe atrophy, the epithelium is so thin that deeper cells are scraped easily. These cells are parabasal or basal in type and are showing nucleomegaly and hyperchromasia. Although the sheet is flat with distinct cytoplasmic boundaries and there is regular pacing between the cells, it is extremely difficult to say whether these are immature metaplastic cells from an atrophic and inflamed epithelium, or this is HSIL because of the high NC ratio and hyperchromasia. The category of ASC-H cannot rule out H cell is most useful. A repeat smear, what is recommended is a repeat smear after application of estrogen for 1 to 6 weeks, and this may resolve the dilemma. The hormonally deaf cells of HSIL will stand out against the newly matured squamous cells. Biopsies are also difficult to interpret in cases of atrophy, and a P16 immunostain is of help to differentiate between metaplasia and H cell small cell type found higher up in the canal. At times, the troubleshooting is at its pinnacle when you are unable to decide whether the morphologic abnormalities are of LSIL or HSIL. This can happen sometimes in HPV infection. Commonly, HPV is associated with mild dyskaryosis or CIN1, but the nuclear appearance may be more comparable with moderate dyskaryosis or CIN2, simply because here we are unable to gauge the maturity, cytoplasmic maturity. In such cases, 2014 Bethesda system recommends that instead of overcalling of SIL grade or CIN grade, one can give an interpretation of ASC-H in addition to LSIL interpretation. Similar is the situation with these cells. Here the nuclei are large, but the cytoplasm is highly variable, and you are unable to decide whether these are cells of HSIL or LSIL. The HCGs, or the hyperchromatic crowded groups of cells, is another troubleshooting condition. These are either microbiopsies or thick clusters of cells, which makes it difficult to determine if the cells are reactive or neoplastic, whether glandular or squamous or endometrial in origin. Cellular and nuclear details are difficult to visualize, but definitely there is loss of polarity of nuclei within the cell clusters, as you can see here. There is marked hyperchromasia and isonucleosis and a chaotic arrangement within the cell cluster. Here also you are seeing significant loss of polarity. In this cluster sheet, there is partial maintenance of the stratification of the cells. These cell groups are more small and round and can favor a glandular or an endometrial origin. An unavoidable cause of thick cell fragments is vigorous scraping with sampling devices like the brushes and brooms. These devices will often pull out aggregates of cells of HSIL from the surface or from endocervical glandular crypts, yielding three-dimensional clusters or hyperchromatic crowded groups of abnormal immature cells. These brushes can often retrieve cells also from the endometrial lining of the lower uterine segment. The nuclear details of cells protruding out from the periphery of these clusters give you some clue to the nature of these cells, whether you can report them as cells of HSIL or simply report it as ASC-H. Who is responsible for all these gray zone lesional dilemmas? Really speaking, the problem is not of the reporting cytologist, but by and large, the problem is with the clinical situation. For example, a chronically inflamed cervix or chronic cervicitis, as you can see in these pictures, is a challenge for the colposcopist as well, as the lesion itself may not show striking and diagnostic features. For example, in this healing erosion, there is a variable intensity of acetowhitening because of inflammation and repair and metaplastic epithelium, as compared to this out and out CIN1 lesion, which is densely acetowhite and has sharp margins. So when the colposcopic findings are ambiguous or evasive, that is when equivocal cells and tissue biopsies walk down in our reporting trace. In order to increase the sensitivity and the diagnostic accuracy of the pap smear, quality control measures should be followed in all laboratories as a part of the quality assurance program, and this can be achieved either by reviewing the slides by a second cytotechnologist and or cytopathologist, also by calculating the ASC-US cell ratio, correlating the ASC-US cases with HPV positivity rates, and correlation of ASC-US cases with the results of colposcopically directed biopsy. I hope that I could bring home the key points that help you make a decision while framing a cytology report, and especially the general categorization of a smear. By and large, the challenges are related to atypical squamous cells, which constitute 4 to 6% of all the smears reported in any lab. The rate of HPV DNA positivity in overall ASC is 15 to 40%. And the ASC-US cell ratio, as I've told you before, also should be 2 to 3:1. The cells in ASC-US, they are mature or mature metaplastic, whereas they are immature metaplastic cells in ASC-H. 90 to 95% of all ASC are ASC-US, and around 10% of all ASC are ASC-H. Go for high-risk HPV testing if the patient is having ASC-US, and especially in women more than 25 years of age. Here, if for women with ASC-H report, should go for colposcopy directly. The risk of HSIL is 18% in ASC-US and 45% in patients with ASC-H reports. HPV DNA positivity is 50% with ASC-US and 30 to 40% with ASC-H. And women who are less than 25 years of age, cytology should be done at 6 and 12 months if ASC-US is being reported. But for ASC-H, the patient goes in for colposcopy, and if colposcopy and directed biopsy is negative, HPV DNA test should be done at 12 months. Thank you, dear all, for your patient listening. Thank you very much.